Good afternoon or good morning to those on the West Coast. We'd like to welcome you to our coffee chat this afternoon. It is called Building the Plane While Flying It. This is part 2 of our series where we are focusing on how healthcare for the homeless health centers are engaged in telehealth. Next slide, please. First, we would like to acknowledge that this coffee chat is sponsored by the Health Services and Resource Administration. I should have introduced myself. I'm Darlene Jenkins. I'm the Senior Director of Programs for the National Healthcare for the Homeless Council. We are a national training and technical assistance partner with HRSA, and we provide training and technical assistance to health centers as well as primary care associations, as well as health control networks. And so this is our acknowledgement of our funder at this time. Next slide, please. Well, this afternoon or this morning, wherever you are joining us, we're going to be concentrating on some of the participants in our document on building the plane while flying it. This document was released in August, and it actually highlighted 17 health centers as well as 2 individuals experiencing homelessness and their experience with telehealth. And we will put a link in the chat for you to be able to see this document, as well as also someone just asked about the slides. Yes, the slides as well as the recording will be available and emailed to you. And so, relax. We are calling this a coffee chat. I have my water here. So we're asking you to get your water, your tea, your coffee, your juice, whatever you need to take this hour and just to sit back, enjoy the time we have together. We're going to take time to, you can chat, put chats, discussions, or questions in the chat. And we also will have a time where you'll be able to raise your hand and we'll unmute you if you would like that option as well. Next slide, please. So I'm going to introduce our presenters. I'm just going to say their name, and then as they give their presentation, they will tell you a little more about themselves. So first we have Casey Harding. She is the director of the Center for Key Populations at Community Health Center in Middleton, Connecticut. So Casey will be our first presenter. Then we will have Amber Price and Patricia Sarvella. They are from the Partnership Community Health Center. Amber is a health advocate at Partnerships in Appleton. And Patricia, Trish, that's why I'm kind of stumbling over her name because I've been calling her Trish all this time. But Trish is the development director at Partnerships. And again, they're joining us from Appleton, Wisconsin. They will be our second presenters. And then finally, we will have Yasmin Quadri, who is the medical director at Healthcare for the Homeless program at Harris Health System in Houston, Texas. So we really hope that you will enjoy these presentations. I know that just hearing their stories when we did our document on telehealth, it was just really exciting to hear the good work that they are doing in their various parts of the country. So now I will turn it over to Casey, who will share her experience there in Middleton, Connecticut.
Hi, everyone. I'm Casey Harding. I'm the director of the Center for Key Populations at Community Health Center in Connecticut. Connecticut is a tiny little state, but it packs a lot of punch, we like to say. It takes about 3 hours to drive end to end, but we have some really significant rural, urban areas of need. And so, we have a really diverse program at Community Health Center. I started out as the Ryan White director in our HIV program around 15 years ago and moved into helping to establish the Center for Key Populations, which really is a comprehensive program that brings together any population that experiences health disparities at significant rates kind of falls under us, and then a bunch of programs that just don't fall anywhere else, so they fall under us. But one of my favorite and our most important programs is our Healthcare for the Homeless program, which is we have 10 sites in either shelters or food pantries or domestic violence shelters across Connecticut. We provide comprehensive medical, behavioral health, substance use care at each of these sites in person up until a while ago. And we send a provider team out. So a provider, usually an NP resident, a nurse, sometimes a registration person.
I think we lost Casey.
Am I unmuted now?
Oh, yeah, there you go, Casey.
Uh-oh, how much of that did you not hear? Well, we'll catch up. So anyways, what I was saying is I forgot to mention when I first started, I don't know if everybody realizes, but it's National Coffee Day today.
Oh.
So I actually have my coffee that my daughter made me right before I started. So like the rest of the country on March 15th, you know, our governor issued a shelter in place order, and we had to quickly move to remote for everything. So we immediately, 92% of the health center went to remote. That included our research teams, our what we call patient service associates. So everybody moved directly to remote. If we can advance the slides. And that included our healthcare for the homeless clients, which was a really interesting thing to try to work out. And I love the phrase, you know, flying the plane while building it, because that's exactly what we did. We had to make accommodations and transition people really quickly. And these are people who had so many other issues that they were dealing with at the same time. Many of our shelters in Connecticut ended up sending people to hotels and doing different things to desegregate. The food pantries closed for a while. So it became really difficult to track our patients and to make sure that they were getting the care they needed, and to make sure that we could provide it in a way that was workable. And obviously the government made a few concessions in letting us do phone visits and video visits and waiving some HIPAA requirements, but it still really required a lot of coordination that just was not part of our everyday process. It also really highlighted for us in particular the disconnect between healthcare and the shelters. So we had always felt like we had really strong collaborations with all of our shelters. We spoke regularly, but we realized that they didn't know what we did and we didn't know what they did in a way that made it really difficult for us to plan for patients in an efficient way. And so we had to work out some of those kinks of how are we going to communicate, how were we going to help the shelters do what they needed to do and have them help us what we needed to do. And, you know, in the end, I think we did a great job, but there were a few kinks along the way and a few things that needed to be worked out as with everyone else. So we did end up doing a little bit of a survey that I thought you might find interesting, some of the results. We did it with CHC and non-CHC patients. So we did it directly at the shelters. We either let people do it on an iPad, or we did it with them, or we had one of our staff do it if they were Spanish speaking. We did it in an area where we have a really great collaboration with the shelter, so it was kind of easy and comfortable for everyone. And then we compared it to a flu survey, just one question. We compared to a flu survey that we had done the previous year, just because the same question was used and we could. None of this went through IRB or anything, so this is mostly anecdotal data that we were using for our quality improvement purposes. But because it was interesting, I thought I would kind of share it. We also did 2 focus groups that we conducted at the shelters with 28 people all together. I'm sorry, I have the buses all going by my house right now. So if we could go to the next slide, I'll just share a little bit of this data with you. One of the most interesting things that we found was, as you can see, 94% of the people we surveyed, and I believe it was 55 or 56 in the survey, and then 28 individuals, so unduplicated in the focus groups. 94% said if they could get a flu shot today, they would. Only 16% would get the COVID vaccine. So we thought that was kind of interesting and delved a little deeper, which you'll see later. And then on a scale of 1 to 10, we wanted to know how easy it was for them to get COVID testing. So we did community testing where we went out to shelters, set up outside in a tent, offered testing, offered a release of information so that we could release that information to shelters to help them desegregate. And as you can see, 76% said it was either extremely easy or easy to get their COVID test, and 11% said they didn't want a test. So even if it had been easy, they wouldn't have. So there's a little bit of a gap there where maybe it wasn't as easy as we would have liked, but not terrible. We were kind of happy with these results. Next slide, please. So this is interesting. So after we did the survey, we did the focus groups, and we really wanted to find out about the COVID testing and why people weren't getting it. And these are just some, and I don't have to read them all to you, but a lot of people said, I don't want to go to the hospital to die. And so in Connecticut and probably nationwide, there was a lot of news coverage about, people being on ventilators for long periods of time, people going into the hospital and a loved one getting put on a ventilator and then never taken off. So I think there was a lot of fear about what could potentially happen if you tested positive. Not a whole lot of confidence in the medical community at that point. And maybe our sense was that they were hearing a lot of information that was conflicting and perhaps just couldn't kind of make heads or tails of it. Other people were just very confident they didn't have it and didn't care that they had been exposed. They just were very confident that they didn't have it. So, and then a few people said that their families just didn't want them to do it. So next slide. A couple of the things we did to encourage testing, testing made it really much easier on the shelters to be able to desegregate, isolate people who had symptoms. And in Connecticut, we found a lot of patients that were asymptomatic. So we really were looking to diagnose people so that we could make sure that the shelters had the safest plan possible. We brought, to alleviate fear, we brought testing to the sites. We went in person and gave results. So at a few sites where we did 90 or 100 tests, the next day when the results were in, we would send our provider out and have them give the results in person, especially if there were positive, so that they could talk through sort of what needed to happen after that. That was also really helpful because the shelter staff could ask their questions about how to isolate people and how to sanitize and things like that. We also provided nurse phone and video visits and in-person visits, just to, again, sort of give a little bit more information, make sure that misinformation wasn't getting through. And also having a provider there who could do pre and post-test counseling, making sure everybody felt pretty confident. And then making sure our messaging was really simple. What we found, again, especially when people were moving over to hotels or congregate living in, a couple of our high schools, we found that like CNN was on a lot and they were getting a lot of information and they weren't quite knowing what to do with it. So we wanted to make sure the messaging was simple. And then a big thing in getting more people tested for COVID was actually having staff get tested and having providers talk about their own tests and having some marketing materials that showed, our governor and everybody getting tested seemed to really make it a little bit more comfortable. Next slide. So this is, again, just to give you an idea, and again, this is anecdotal. It's nothing we went through IRB for, but most people had a phone visit. Most people felt it was really easy. Most people were really comfortable with it. And a lot of them were very likely to do it again. So, 8% said they were not as comfortable as we would have liked. So obviously we wanted to delve into what made that not quite as comfortable. So we can go to the next slide. And these, again, I don't have to read them all, but, there were barriers for people who were unsheltered and coming off the street to get their test, but there were also barriers for people who just had historically gotten their care at the shelter for various reasons, sometimes because they had once lived there and now were coming there, but they had some significant differences in why they didn't want to see a doctor. Some of it was technology, as you would expect. Some of it was, I have the technology, this is just not what I'm interested in using it for. Way too much other stuff to do. I don't have a need to call. I don't like going to the doctor even when it's not COVID, so why would I go when it is COVID? On the next slide, there's some more information on the non-shelter patients. So they seem to have a little bit more trouble connecting to telehealth, not having a ride to go to the shelter in person to access the technology, just not liking the phone visits. One person had tried it and said, I'm never doing that again. And then a lot of people described to us situations where they just didn't have any privacy or a place to do it, or they needed to ask for help to access technology and didn't want to let anyone know that they needed help. So, those kind of things, exactly what we sort of expected. Next slide. So this is just to give you a little bit of an idea of what we've kind of worked on in terms of, looking at what people told us about what was hard and challenging in those times and trying to figure out models of care that might work for them. And obviously we were very specific to look at, in Connecticut, we have 10 sites, our healthcare for the homeless sites. Some of them are going to allow us to go back in person for a little while. Some just don't want the footprint at their sites. So they're really not interested in having us in person. So we're trying to figure out ways to continue telehealth. So, looking at that hybrid model of transitioning back to partial in-person care, we have a nurse practitioner residency program. One of the things we're looking at is, could we have a resident on site in person and a provider, a mentor provider off site via video, and they could kind of collaborate. The person that's in person could really work on setting up the technology and educating the patient on, the consenting, and then perhaps even do some education after the visit, but that the provider via telehealth would be the main provider. We're looking at setting up telehubs in the shelters. So we purchased iPads that we provide to the shelter, and you give them to the shelter, they have them signed out by patients for their visits, and then they give them back. And the unfortunate part about that is it requires a lot of work on the part of the shelter, and they're not fully staffed. They're kind of working with a skeleton crew. So that makes it difficult to have a person in charge and a process. And one of the other things we've looked at is, if we are able to be there in person, trying to schedule other visits like behavioral health at the same time we're there in person, and us sort of being responsible for checking out the iPads and stuff like that. We also have looked at just putting a desktop in a room that would be on, and the patients could access the room and have their own login. They could log into the computer, they could click on the link, and we could do it that way. So that kind of alleviates any staff person. It gives them the privacy, but still kind of working out the kinks in all of these again. We've been doing a lot of technology education with our patients. So I think my son is a patient at CHC. He's 20 and he has autism, very high functioning, but he does all of his visits via televideo right now. And he really struggled, and he's a 20-year-old. He's been doing social media since he was born practically. But he really struggled with what link does he click on, and there's a little bit of a wait where it says you're in a waiting room. And so one of the things that came out of me watching that was to know that ahead of time it was good to prep our patients and let them know what it would look like and how it would feel to them and how they could be comfortable. And so we've been doing a lot of education around that. We have little flyers that we hand out, letting them know that it's not a big deal. If they get the phone call and they're not there, we'll try again, or they can call us back, trying to just, again, work around sort of the challenges they have. We did get a grant from FIC to provide phones and minutes. I will tell you, this is not all that successful. I was so excited about this. We'll give you a phone, we'll give you a gift card for the minutes. We can keep uploading the minutes. It doesn't work. It doesn't improve our no-show rates. People still, with the phones, just don't access the service. We send text reminders 2 days before, 1 day before, the morning of, and then if it's an afternoon appointment, we'll sometimes send one an hour before. That doesn't really help as much as you would expect. We have one thing that has been taken advantage of a lot is increased nursing visits. I think our patients were really familiar with our nurses and wanted to engage with them. And so the impetus for that is really that they like the nurses and know them and feel comfortable with them because they've spent so much time with them. And so they're more apt to attend a nursing visit than a provider visit sometimes. And so we've used that to our advantage, especially with our substance use patients, trying to hook them up to behavioral health and get them into, you know, we're still struggling to get groups up and running for our substance use patients, but the nurses have been really instrumental in keeping our patients engaged and not letting them fall out of care. And then also, you know, we're really monitoring the patient charts carefully. We're making a lot of phone calls. We're looking for patients who have the potential to fall through the cracks. So we've assigned an administrative person, and their only job is to kind of go through the last 6 months and the previous 6 months and look at patients who may need a visit and not have one. The one big thing, which I don't know why I put it last on the list, is the central phone contact. So making sure that our patients knew how to get us, because before we had different sites and different contacts, we made one phone number. It's answered by someone 24 hours a day, and that's it. That's the only thing you have to know to get a hold of us. It's behavioral health, medical, nutrition, anything you need. If you're one of our healthcare for the homeless patients, you can call that number and we will get you where you need to go. So that was a really important one for us. And then the last thing that isn't even on the list was home monitoring equipment. So looking to make sure that whereas traditionally people would have come in once a week for a hypertension check, they're no longer able to do that. And we certainly don't want them coming in once a week. So we were able to purchase home monitoring equipment like blood pressure cuffs and not A1C machines, blood glucose monitoring, things like that, so that people had easier access to those kind of things and could participate with their provider in giving those numbers. I don't know if there's another slide. So these are just, I'm not going to read through these, but these are just some patient comments on really, we also saw addressed in the survey, it was interesting. People said that they had increased physical health needs, but yet they weren't accessing our services. And one of the things we realized it was more, you know, their physical needs. It's not that they couldn't access the services they needed. It was them describing to us they felt physically poor because of the circumstances. So we immediately took that as, oh no, we're not responding the way we should. But what they were reading that question, do you have any physical have you had more physical challenges over the last 4 months? They were reporting, yes, I just don't feel as good as I used to, but more because of the circumstances. So that was kind of an interesting thing with that. And obviously mental health needs, which we're trying desperately to address and work on with phone, and hoping that, you know, we're able to continue the regulations that allow us to do phone visits, because those are certainly easier for patients than video visits. And I think there's a couple more slides, but mostly just quotes. No, there you go. So I think, I don't know how I did on time, hopefully not too bad. I talked a lot, but I just want to thank everybody for participating. This is a wonderful opportunity and I'm so excited to be a part of it. Please contact me anytime if any of this information was valuable. I can share any of our surveys or our questions or our marketing materials. Happy to do that. So just let me know.
Great. Thank you so much, Casey. We'll give a few minutes just for anyone to enter a chat if you have a question for Casey, or if you would like to raise your hand to ask the question yourself. We'll give some time for that at this moment. And I'm watching our time to make sure we're not going over, but does anyone have a question for Casey at this time? Okay, if not, thank you so much, Casey. We're going to move on to our next presenters, Amber and Trish.
Good afternoon, everybody. I'm Trish Sarvella from Partnership Community Health Center, joined with Amber. We are going to tag team this. Casey, what a great presentation. It's fabulous to go after you and see what a large statewide program has to offer. And now we're going to pare it down a little bit for our smaller program at Partnership. We're located in Appleton, Wisconsin, and if anyone's familiar with the Midwest, we're just a little bit south of Green Bay. But I need to do a little shout out because prior to coming to Partnership, I had worked at the Holyoke Health Center for a number of years in Massachusetts. And when we moved out to Appleton, one of the things that Holyoke and Appleton shared, if anybody knows this, is Harry Houdini. And Harry had lived in Holyoke and then moved to Appleton, and they were both paper cities. So when I moved out here, one, I didn't think that I would necessarily continue to do community health center work at this level, or that in Appleton there was a rather large and growing population of people experiencing homelessness. And as we look at the community of Appleton, it is one of the more affluent communities in the state. It's one of industry, close to great, wonderful outdoor activities and all sorts of other things that the chamber boasts of. But what it doesn't talk about is really the challenges that people have as the bottom has fallen out of employment. People are coming out of jails with not places to go, a rising substance use disorder problem with our young people and adults, a severe alcohol problem in our community. And the fact that in our school district, there's upwards of 600 kids experiencing homelessness and thousands of people who are either near homeless or living in shelter. So our work as a community health center really began as a free clinic 20 years ago in the basement of the Salvation Army, which is an interesting story for a health center to kind of bubble up, really as a result of two hospital systems and benevolent people in the community who really wanted to take care of those people who were unnecessarily visiting the ER or having preventable hospitalizations, all the things we talk about today, and really people who were needing care and getting food at the Salvation Army. So we began in the basement as this free clinic. And when there were, federal funds that came in the mid 90s, we were then able to become a full service community health center, which I was not part of that, but as we quote unquote grew up into ourselves, we really had our roots embedded into serving people, either shelter-based clients or people experiencing homelessness in certain ways. But as we moved on, we opened up primary medical, dental, and our roots sort of, needed a little bit of watering. And for many years, we felt like we were really doing the right work and getting with the people that really needed the care. And next slide, please. A survey came into our community where Project Rush, if some of you are familiar with this, out of Minneapolis, came in to really survey people living in shelter and outside of shelter to look at what the barriers to care were and what some of the primary roots of their poverty was. And many people said, and not a surprise, that they really felt like that they didn't have access to healthcare. Healthcare was unaffordable and it wasn't something that they felt that they had a relationship with. And here we as a community health center were like, where are we missing the boat on this? Because this is really kind of who we felt we were and are. And clearly we were missing the mark. And as we really went back to figure out the best way to begin to engage this population, we knew that, it was not a kind of quote unquote, build it, they will come and just wait for people, but we really needed to get at the grassroots, engage people where they were at. And we felt, that we needed to embed our work in 2016 into a transitional living facility where people were either post-incarceration, dealing with substance use disorder, trying to live clean and sober, people living debt-free, people who were registered sex offenders, and begin to work with our shelter-based clients and really with people in this transitional program. And this was a huge eye-opener for us as an organization, maybe not as the people delivering the care, but as a health center, to say we really needed to find new ways to engage this population in care. So in partnership with, and you can see our snazzy logo that we did here, calling it Bringing Healthcare Home, as we were bringing healthcare to where people were actually residing with our community partners of the shelters, transitional, post-incarceration, and then job training. And this was really a way that we were then able to build relationships, begin to get a trust part going, and deliver care. So as we set up this structure, next slide, please, we were really able to begin to recognize that getting care and moving people into, primary care or dental was more than just a referral, more than just an episodic 20-minute visit. It was really helping people understand and helping us understand where patients wanted to start. So as we were doing all of this great innovative work and engaging people and doing some great outreach strategies, COVID hits. And we need to shut down our COTS clinic, which was at the site of the transitional living facility, and then change all of our outreach strategies. So we were no longer out and about in the street. The safer at home order was put in place on March 16th. We really needed to figure out a new way to do business. Well, as March and April and May came, we knew that we needed to stay in touch with these patients, but we in this state had not really felt COVID yet. We had all of the restrictions, we had all of the safety pieces in place, but our caseload, super low. Nobody was really necessarily getting tested. We were locked down. There really wasn't that panic. As of last week, we have surged. We have had over 2,000 new cases a day. We are behind the East Coast clearly on this, and we're really beginning to feel that we had a little bit of preparation time, a little bit of time to identify some strategies that we didn't have to put in place immediately. And now that we're facing this enormous surge in the community and cases, particularly with our most vulnerable patients, we've really needed to figure out a way to do things. So as we did this, Amber's role as the health liaison really became critical as a strategy to really, one, stay in touch with these patients, and then figure out new ways to continue to engage them in care. So Amber, I'll turn it over to you for the next part.
And Trish, you didn't mention the renovations, right? I can talk about that.
No, absolutely.
Yeah, so I'm the health advocate. I actually started with partnership right around the time that we were opening the clinic at the COTS Transitional Shelter. And currently that clinic is closed. We are pretty small there, and the staff workspace is just not set for social distancing. So we had received some direct relief funding to help us to do some renovations over there. So that way it's just safer for patients and staff. And unfortunately, it's taking a little bit of time to get everything up and running from the renovation. So my role as the health advocate has become even more challenging. Typically, I would be the person that was working at that clinic, checking patients in, but also out at the shelters in person, doing outreach every single week. With COVID, the in-person outreach has just not been feasible. So just needing to look at some different strategies, thinking about what can we do to stay connected with these individuals. In the few years I've been doing this work, I've learned that it's those patient relationships that are just critical to the care for these individuals. You know, they don't trust a lot of healthcare systems. Maybe they've had bad experiences in the past. Sometimes I found I had to go to the shelter multiple times before they would finally approach me and ask, hey, what are you doing here? And, it just took some time for them to ask for help. So just thinking about, well, what can I do now that I can't be there in person to connect with these individuals? So started kind of thinking outside of the box because, even though I can't be in person, we still have all this virtual stuff going on, not only with patients, but with community partners that we had already been collaborating with. I had already been connected with the shelters just from doing my outreach. So just looking at ways to grow those partnerships. One in particular at the Salvation Army, I had been doing maybe monthly to bi-weekly outreach, didn't have a whole lot of direct contact with the staff there other than just checking in at the desk, when I would be there for outreach. So just actually connecting with one of their directors over there and saying, hey, we've got some ideas to keep some of your clients connected to healthcare services. Wondering if you would be on board. So one thing that we brought up was having a health assessment table set up there, because usually when I was doing in-person outreach, I would do this health assessment in person with the clients as they were coming to the table, just to see what services they were interested in. Not only is it informative for us as a health center, but it allows the client to say, this is the service that I am currently prepared to receive. Maybe they'd had a lot of previous trauma, and although they might recognize they have a need, they're not quite ready for it. So just having them say, hey, this is what I'm okay with right now. So trying to think about, can we have them fill out an assessment, while I'm not physically present there? So for a couple months now, we've had this table set up in the hallway of the Salvation Army. Although they don't have clients going in to eat lunch anymore, they are open so people can go in and use the bathroom, because that's an issue in our community, is not all the public bathrooms are open yet. So yeah, I mean, we've got this table there. It's still pretty new, but we have received a couple different assessments, and I think really we're continuing to spread the word about our services. We have flyers available at the table. I'm seeing that people are taking our flyers, and those that have filled out an assessment have said, yes, I do need services. So I think as more and more people start to see this table, we will see that we're able to connect, maybe actual new patients to our services, which will be huge. But yeah, even though it hasn't picked up quite yet, I mean, just looking at the partnership I've been able to grow with the Salvation Army, I think will help us in this whole experience. If you could go to the next slide. Okay, and Trish, do you want to do a brief intro to care messaging?
Sure. And as we had to really make that change when we closed down the COTS clinic site and actually really scaled back at the health center level, we needed to move into this virtual platform, whether it was by phone or by Zoom. And I really appreciate what the previous speaker was talking about with the challenges that people had about, getting into Zoom, how to do all of this. But this was a way that we felt like we could really continue to expand our relationship with people in shelter, that getting the phones going and getting people really understanding, one, we're still here, we haven't gone away. And yes, you can connect with us through telehealth in whatever version that is. And so as we got that grant that Amber mentioned, the direct relief, and if there are people on the call who aren't familiar with direct relief, I encourage you to reach out to them, because they specifically fund community health centers with special types of grants. We've usually just received their lotion and Vaseline, and lo and behold, they had this great COVID focused grant that was funded by some, work that P. Diddy was doing, particularly around getting people connected to care. So we applied, we got the money, it's covering some of our renovations, but what we also put towards this was using a platform of patient texting called Care Message. One of the things we really liked about this is that we could get our own customized messages out to patients quickly. We could also have the feature of having them respond back to us. We could put it into Spanish. And even though we trialed out just what they call the Care Message Lite platform for health centers, it didn't go right into the electronic health record. We are moving forward with these funds in October to really purchase the entire platform that would allow us to look at UDS measures, look at HEDIS measures, figure out, are we texting out people in shelter who have diabetes or hypertension or need to get in for a flu shot? How are we really able to make sure that we stay in touch with people? And we've really found that, at least here within our patient population, this has shown some preliminary success. And I love the messages that we had for you guys to take a look at here. Partnership is here while COTS clinic is closed, or hi, this is Amber. Ways to just reach out to patients so we know. Now we look at the results of how many texts were delivered and who responded yes. A couple of other more successful ones were, are you uninsured? Can we help you with that? Getting people into Medicaid enrollment. We'll be doing some around open enrollment for the marketplace. And just using this as a strategy was a way to personally get ourselves into people's hands, whether it's on their phone or their iPad, or, you know, even just getting some comfort messages out during COVID, to keep people connected. So I think that's been a really, as it's beginning to show preliminary results, something that we're really going to see ramp up as the months go forward.
Yeah, and one thing that I want to highlight that we kind of have showcased here is that so when we personalized the message and had it come from me instead of just looking like it was from partnership in general, I mean, we definitely saw an increase in response rate. Some people were just, you know, like texting a smiley face to say hi, and others, you know, said, hey, I need help. So I was able to connect with a few different individuals, whether it was to schedule an appointment, to verify when their upcoming appointment was, put in for a refill. And one individual specifically, so he was living in another state at this point, but he had received services from us previously. And he was someone that was struggling with affording his medications because he was currently in between insurance. So even though he was no longer in the state, I was able to walk him through some different prescription assistance options that I know about. And he was just grateful to have somebody to talk to about, you know, his concerns. So, and I feel like he's someone that I wouldn't have probably connected with otherwise because, you know, he wasn't living here anymore and hadn't received care in a while. So just really an eye opener for me, just to see, you know, how far those relationships go and how important those are for the patients. And just seeing that, you know, even though I was calling to check in with them, you know, many of them were even asking, hey, how are you doing, you know, with all the changes. And I mean, just great to build upon the relationships that I had already been working on before COVID. Trish, do you have anything
So
else to
no, and so
add?
as we're moving forward, and you can all imagine that we could talk for a while about this. The other part of our grant that came through Direct Relief was the opportunity to purchase some iPads and set up some remote sites, and eventually, you know, we'd love to have remote monitoring and all sorts of snazzy stuff. But where we're starting with, you can go to the next slide, please, is looking at embedding these iPads into some of the shelters, starting with our resource center and setting this up not only, you know, with all of the things we need to do from an MOU standpoint and, you know, HIPAA, but also setting up PDSA cycles so we can really measure, you know, the impact of this, and is this actually working? What's happening? How are patients feeling about this? Where are they, you know, connecting? Is it primary medical or is it behavioral health? We're soon going to be moving on to an MAT program, and we're also doing our health insurance remotely. So if we can help people do this and then do the PDSA cycles and really make sure that we're maximizing the access to the virtual care and really advocating for ongoing telehealth opportunities, particularly for this population, we're really excited that this is going to start off, and we're aiming to do this at the beginning of October to get it going. And really the timing is right now that, again, we continue to surge and see numbers, so this will keep patients outside of the clinic and safe and be able to access their care this way.
And I do want to talk just briefly about some of the reasoning behind setting up an iPad at the Resource Center. So we've been looking at some numbers, specifically those individuals that were established patients at the COTS location, which is currently closed for renovations. And out of all of those patients, since we closed at the beginning of April, only 9 of our primary care appointments by them have been over Zoom. So, I mean, many of them are are over the phone. They just don't have easy access to Zoom appointments. So we really are hoping to make this, an actual reality for them to be able to access the Zoom appointments. Right now, with not having this other satellite clinic open in the shelter, transportation is a barrier to get out to our other facility. So I think this will just be huge once we get this up and running, to have people that are right now maybe not as connected to care as they were when we were open at COTS, being able to access care virtually and not have to travel for it. And Pillars, the organization that we're working with, has just been huge in helping to facilitate all of the needs to get all of the planning happening. And they're actually going to be taking on the iPad schedule and working with their clients and helping everyone as they're doing their own appointments, to make sure that clients understand how to use the iPad. I think it's really a great collaboration, and I'm excited to get this rolling in the next couple weeks.
Absolutely. And one of the things that I think has been a real benefit of this is really training the shelter staff. So they're really extensions of the health center and are able to really get connected and know what's there and connect those clients up to coverage and care. Next slide, please. So we are happy to take questions and have you get in contact with us, share our materials. We've done a number of different texting things that we're happy to get out to you, as well as keep you posted on where things are going with our Zoom stuff. We really recognize that community partnerships and trust relationships with the clients are really what's going to make this successful, as well as local and state and national advocacy around the importance of keeping telehealth as something viable going forward, particularly for this population. So we're thrilled to continue the work and look forward to hearing what everybody else is doing around the country as well. Thanks so much for including us in this.
Great. Thank you so much, Trish and Amber. We really appreciate the information. We have one more speaker, so I'm going to move us quickly along to Dr. Kadri to make sure she has time. But if you have a question for Amber or Trish, please put it in the chat box and we'll make sure that that is answered. But now we'd like to move on. Dr. Kadri, we're ready for you here.
Yes.
And I should mention, I'm also putting the link to the Building It While Flying It document in the chat. So that's for everyone as well. Okay, thank you so much, Dr. Kadri. You're next.
Thank you, Darlene. What an honor to be able to speak on this forum. I am so excited to share our experiences. I am Yasmin Quadri. I'm a family physician by profession, faculty, Baylor College of Medicine. I am the medical director for the healthcare for the homeless program with Harris Health in Houston, Texas. Our program has been in place since 1987. We started when the first fundings came out after the McKinney Act for addressing the care for the homeless. We were a smaller entity at that time, provided healthcare in a few shelter sites, and were providing just point-of-care services at that time. In 2010, by 2010, we had made significant progress and were in 5 shelter sites and had a mobile medical unit at that time. And in 2012, when I became the medical director of that program, we expanded more towards providing more holistic care for the program. I had moved from one of the ambulatory care clinics at Harris Health, where I was the medical director. And so when I saw the discrepancy in the care that was being provided at the homeless clinics, and being under the umbrella of the big Harris Health, to me that was kind of, I couldn't understand. I was trying to make sense of why is it that the ambulatory care clinics is providing so much more, which also serves the underserved, but when we come to the homeless, there is a discrepancy in the quality of care that is being provided. So we were able to have negotiations and move our services to a more robust level and start providing a holistic care for the patients who are homeless, being under the umbrella. We are HRSA funded, but we are under the umbrella of the big organizations. So there are a lot of advantages of having that partnership. And we moved to where now 4 of our locations, we have 9 locations total, of which 4 of them are patient-centered medical homes. And we are providing a bunch of services. We provide eligibility services 5 days a week. We provide medical care. We provide dental care within shelter sites. And then we also have mobile medical and dental units that go out into the community. As you're aware, Houston is the 4th largest metropolitan city in the country. So there is a huge need for these programs. And we provide also an outreach service. We have case managers in our program, a couple of social workers, and we have a health educator who goes around the shelters doing tobacco cessation, diabetes, chronic healthcare, hypertension education, and projects and so forth. We're also linked with the MVP program that started last year with the 2 emergency rooms, the 2 big emergency rooms, which are the safety net hospitals, Bentop General Hospital and LBJ Hospital. And MVP is a multi-visit patient program where patients are making 6+ visits to the emergency room, and we identify those patients and try to link them into care so that they're not making non-emergency emergency room visits, and which were previously seen for things like, weather-related conditions, things like medication refills, simple things that can be taken care of by better case management and better integration of care. So with that background, I would like to talk a little bit about how we moved on to COVID screening and telephonic care, and now to planning to move towards video visits. Lo and behold, when COVID came, we were open in 9 shelters providing care from pap smears to physical exams to you name it. And then suddenly it's like the patients are afraid to come in. What do you do? So I do have a day of clinical service that I provide in the ambulatory care clinics with the Harris Health System, which is underserved patients, not homeless. So from that one, Harris Health was able to implement beautifully in a very little time telephonic encounters immediately to take care of their patients. They had decreased the number of patients being served during COVID to 50% face-to-face and 50% telephonic visits. They have since moved now to video visits, My Health video visits, doximity, which we used in the past, and now they've gotten a contract with a program called doxy.me, which is personalized to the Harris Health System. So when I did my first telephone visit at the ambulatory care clinic, I'm like, this is so simple. This is easy. We can do this for our patients, because at the homeless patients, I mean. So the thing was, how do you get the buy-in? You have to talk to all the different shelter sites that are, people are not knowing what's going on with COVID. You're hearing something new happening from the CDC, from the news channels, and people are talking about all kinds of stuff. Patients are afraid to come to the clinic, and how do you manage that? So basically what we had to do was me, our nurse manager, we sat down one afternoon and spent about 6 to 7 hours just sitting and saying, how can we serve our patients? How can we take this model that exists already at the ambulatory level and bring it into our homeless shelter clinics and the outreach? So we came up with an idea of a pilot. Let's start off slow. Let's start off with one location and see how that works out for us. So we found a champion who was willing to do this. We walked her through the telephone that same afternoon, had a conference call, worked out the workflow, and lo and behold, by the end of the week, she was seeing telephone visits in the program. And how did that happen? Many of our patients don't have telephones, so obviously we had to figure out a way of doing that. So we have had a good working relationship already with several of the shelter sites, because we do quarterly meetings out there, and we have a good professional working relationships. So we had to first educate them on COVID, what it is, then educate them on what the needs of our patients are. They need medication refill. They need a person to hear them out. They're afraid, they're scared, they're in programs where they're isolated from family, they're homeless, and there have been outbreaks in the shelter. We had a shelter where there was an outbreak of 102 patients. How do you leave those patients alone without having to speak to a therapist, a clinician, and so forth? So lo and behold, they agreed. And we set up a room where the patients would come in, and the care was completely provided by our staff. Our nurse or the intake person would go in, and in that room, we had just one landline, and the patients would come in and talk to the provider. They were so excited. It was amazing how well it worked for us. We were, half and half about maybe the patients won't listen, they need to see a face and so forth. But fortunately, it worked out really well. We started off initially with a third of our patients being on telephone visits. When it started working well, we increased it to 50-50. Right now, we still have 50-50. There is one provider who's on medical leave, so she does telephone visits 100% from her home. And this has been a path actually for doing the telephone visits. Like the other providers, like the presenter said, we have also received some CARES funding for COVID-19, and with that, we started COVID-19 testing, and we have been doing our testing since May. Our telehealth visits have been going on since March, so between March and May, we've had a little bit of time to get the buy-in for our patients. Patients have fortunately kept the telephone appointments and the follow-up appointments. One of the patients actually even commented, "I'm so excited that I can hear a voice that I know." And this was from a street homeless patient. We have a clinic, Lord of the Streets, which is located downtown Houston, where the street homeless come into the shelter site for clinical visits and certain other ancillary services that are provided to them. And so we have had a good response. However, a lot of legwork had to be done on our part. We had to figure out a champion. We had to build a train-to-trainer model. Once that person at the pilot location did her work and it worked out, the kinks and the successes that she had were shared with us. We were having telephone calls almost every day between the three of us, the pilot provider, the nurse manager, and myself. And then we were having weekly conferences, Zoom conferences with our providers, because we are spread out in 9 shelter sites and a mobile location. So that communication had to go on so that there was a seamless transition of care from face-to-face to telephonic visits. Now, having said that, I would also say that we have had some patients who have not been satisfied with telephonic visits and have wanted to continue the face-to-face, and we have continued to do that. Most of these are patients within shelter locations, and sometimes those patients would come in and they were PUIs, presumptive positives, and they felt that, since they could not be seen face-to-face, it was a really good thing for them to see that another option was available for them. And so the telephonic visits have continued, and we have had such great successes that I would like to quickly share one success story that was actually a telephone visit with myself. I spoke with a patient, and he was in a rehab center he was discharged from the hospital after having an acute exacerbation of CHF, and he had to be rehabilitated. The poor patient was discharged from the hospital and had just one set of clothes. And when I called him and talked to him and I said, "How can I help you today? This is the doctor from the homeless clinic." And his question to me was, "Doc, I'm fine. They're taking care of me in rehab. I need clothes." So guess what? We got him connected to a case manager. Lo and behold, the next day, he had a pair of clothes to change into. So for our patients, what I like to say is not just giving them a prescription is healthcare. Housing is healthcare for them. Taking care of their social determinants is healthcare for them. So we have to meet the needs of our patients where they are and what they need. And once I was able to tell that patient that we may have a resource for you, then he kind of, slowed down a little bit. His anxiety was alleviated, and he started talking to me about his health problems, his heart condition, and so forth. So I tell my organization leaders, since we work with a very big organization, I try to tell them all the time that, although not just our organization, but every organization that works with the homeless, that our patients are different, their needs are different. We need to have healthcare for the homeless providers, staff, and experts be on the table when it comes to taking care of our patients, when creating policies for them, when creating workflows for them, when creating extensions of care for them. And our providers are all trained in motivational interviewing, trauma-informed care. There is a process by which we deliver care to our patients. And to me, that is an ideal way of doing it. Of course, we meet them where they're at right now. And because of the COVID and the eviction process that's going on in the city of Houston, we see a lot of brand new families with suitcases under the bridges and so forth. So our the next goal that we're working on is we have also purchased tablets, and we plan to expand our outreach using tablets and setting up video visits and telephonic visits, doing eligibility on site, trying to help these patients where they're at. So these are some of the things that we've worked with and have been our experiences. And it has been a lot of work, a lot of thinking outside of the box. Trying to work really hard to get buy-in from the upper leadership. They have been very supportive, but at the same time, it's a lot of trust building and a lot of successes and failures that you have to deal with very quickly in very little time. So these are some of my stories from Houston, Texas, and I'm open for any questions that you may have.
Thank you so much, Dr. Quadri. And this is her contact information. We'll take a few minutes. We're a little over time, but we do want to take the time to allow the audience to ask any questions. That's what the coffee chat is, just to give a chance to, we bring in the experts and they tell their story, share experiences, and then we give you a chance to ask questions. So if there's anyone that would like to ask a question, please put in a chat or raise your hand. We're open to that. In the meantime, if we have any questions, just again, put them in the chat. Joy, if you could go to the next slide, just as, that's just a reminder for the chat. And then the final slide for us. We're just want everyone to know the council is sponsoring some upcoming learning collaboratives on outreach and enabling services, on BMI and telehealth, transforming clinical care in the area of type 2 diabetes, consumer leadership learning collaborative, medical respite, as well as supportive inclusive recovery, addressing the intersection of gender, behavioral health services, and homelessness. And if you'd like more information on our learning collaboratives, please visit our website where there is more information there. I'm looking at our chat. Joey, is there any questions that I've missed? I'm not seeing any. Is there any questions in our chat that we need to address?
Not that I see, no.
Okay. Well, I want to just thank our presenters. This has been great information. Again, if you'd like to know more about the sites, please do look at our document that I uploaded in the chat on the case studies. Also, please reach out to our presenters. They have been very, very open and honest with their successes as well as their challenges. And so they're willing to share whatever information needed. Also, Dr. Quadri has shared with us in the document her workflow that she developed when dealing with or coming up with the flow for the telehealth. So please look at the document and look at the workflow that she has adopted for her organization. Again, I want to thank you, Casey, Amber, Trish, and Dr. Quadri, Yasmin, for your time and your expertise and just being a wonderful partner to the council. And we want to bid everyone a great day. Be safe. And if you have any additional questions or comments, please fill out the evaluation. This is the way that we're able to produce and to give information to you based on needs and observations. So please fill out the evaluation, give us feedback, and we'll try to meet the training technical needs that have been identified. Again, thank you so much. And with that, we will close our coffee chat and have a great rest of the day. Bye-bye.
Thank you, Darlene.
Thank you.